Ibogaine is a naturally occurring psychoactive indole alkaloid, primarily extracted from the root bark of the Tabernanthe iboga shrub, native to Central and West Africa, especially Gabon, Cameroon, and Congo. It has been used for centuries in traditional Bwiti religious and healing rituals for its hallucinogenic, oneirogenic, dreamlike, and introspective effects, often in rites of passage or spiritual ceremonies. In smaller doses, it acts as a mild stimulant. In larger doses, typical for therapeutic use, around 10 to 25 milligrams per kilogram, it produces a prolonged psychedelic experience lasting 24+ hours.
Ibogaine has complex multi-target pharmacology. It interacts with opioid receptors, including kappa and mu, serotonin transporters and receptors, NMDA glutamate receptors, nicotinic acetylcholine receptors, dopamine systems. Its main metabolite, noribogaine, is longer lasting and contributes significantly to effects, particularly as a serotonin reuptake inhibitor. This polypharmacology is thought to reset addiction-related neural pathways, reduce cravings, and alleviate withdrawal symptoms rapidly, often within hours, by modulating brain reward circuits, promoting neuroplasticity, and providing profound psychological insights. The experience typically has phases: a visionary, dreamlike stage with vivid imagery and memory review, followed by introspection and integration.
Ibogaine gained modern attention in 1962 when Howard Lotsof, a heroin user, discovered it dramatically reduced withdrawal and cravings. Since then, anecdotal reports, observational studies, and some clinical data suggest it can interrupt opioid, cocaine, alcohol, and other substance dependencies, sometimes providing weeks to months or longer of reduced cravings after a single dose. It stands out because conventional treatments, methadone, buprenorphine, often require ongoing medication, while Ibogaine offers a potential one-and-done reset for some people. Research also explores benefits for PTSD, depression, and traumatic brain injury, with derivatives like noribogaine or analogs, 18-MC, being developed to retain benefits while reducing risks. Ibogaine is not risk-free. Key issues include cardiotoxicity, QT interval prolongation, arrhythmias, and rare fatalities, often linked to pre-existing heart conditions, polydrug use, or lack of medical monitoring. Other side effects: nausea, ataxia, loss of coordination, tremors, insomnia, potential psychosis or mania. Long duration and intensity make it unsuitable for casual use. Deaths are documented but often occur in unregulated settings. Proper screening and cardiac monitoring in clinical environments greatly reduce risks.
United States. Federally Schedule 1. High abuse potential, no accepted medical use, making it illegal outside research. However, states like Texas spent over $50 million for trials, and Arizona are funding research, and the FDA has allowed studies on Ibogaine derivatives like noribogaine for addiction and mental health. Veteran studies at Stanford have shown promise for PTSD. Legal or tolerated in places like Mexico, Canada, limited access, and some other countries for treatment. Ongoing clinical trials focus on safety, efficacy for opioid use disorder, and safer analogs. Only limited randomized controlled trials exist so far. Ibogaine matters because it represents a novel, rapid-acting approach to one of society's toughest problems, addiction, amid an opioid crisis. Its ability to combine neurochemical reset with deep psychological processing intrigues researchers, but significant safety hurdles, legal barriers, and the need for more rigorous evidence keep it controversial and largely unavailable in mainstream medicine. Derivatives and better regulated protocols could make it or improved versions a game changer if trials succeed. Always consult medical professionals. Self-experimentation is extremely dangerous.